Alright guys, so this is going to be one of the last videos in the wound healing section, and we're going to be extending the optimal healing portion of the series. It's going to be just this last video, and then we're going to have one more video talking about the advances in wound care. So without further ado, let's get started. So I just want to talk about the resources. First of all, of course, as per usual, we're using the Peterson's Principles of Oral and Maxillofacial Surgery, the First Aid for the USMLE Step 1, and OpenStack's Anatomy and Physiology. And if you see this exclamation equal sign, I kind of included a key here, and I'm taking things from my software programming background and bringing them into here. So when you see equal, that means equal, and when you see exclamation equal, that means not equal. So less letters, less words, less reading, all right? It truncates and slims down some notes. So let's talk about optimal healing and radiation. So of course, radiation causes inevitable damage, and osteoradionecrosis is a big deal. So when we think about patients with osteoradionecrosis, generally we think about treating them with hyperbaric oxygen therapy. Now, damage begins immediately, but the effects start to manifest much later, on the order of weeks, months, or even years later. Now, damage occurs to DNA, and generally this is why cells that replicate the fastest tend to get affected the worst. Think about skin cells and cells in the bone marrow responsible for hematopoiesis. To take it a step further now, it's those cells that replicate the fastest that tend to be associated with the most acute of the negative outcomes of radiation. Now, a big point here, though, is that long-term effects are directly related to high doses. So in the oral cavity, when you think of radiation, you think of dermatitis, oral mucositis, and osteoradionecrosis as the big hitters. And when you think of the two quickest offenders, you think about mucositis and dermatitis because those have some of the highest cell turnover even in a normal physiologic state. And I shouldn't say that those have the highest cell turnover. It's the tissues that are involved in those processes that have the highest cell turnover, right? What we're really watching in those cases is we're watching the manifestation of the present cells following through with their cell cycle, but it's the cells that replenish them that are unable to keep up, with transcription and translation taking a heavy toll from the radiation. There are a lot of things in the recovery process of oral mucositis that look like things you've seen in wound healing, such as cytokines that promote cellular infiltration and collagen deposition. And a big thing to remember here in the healing process is that we need blood flow and perfusion to facilitate healing, but this whole radiation process is damaging to those vessels, as leukocytes adhere to endothelial cells and thrombi start to clog the vasculature. Okay? So, radiation, of course, causes obliterative vasculitis, right? And that comes with some permanent and some not so permanent things. So the permanent things, of course, are collagen hyalinization and fibrotic change. And the not so permanent things are things like tissue hypoxia and the risk of infection. And the reason we're saying not so permanent is because these things often need the encouragement of something like hyperbaric oxygen therapy, but they can be attenuated, right? So complicated healing after trauma or complex surgery, we think about things like dehiscence and incomplete healing in cases where patients were irradiated. And this healing process can require debridement and vascularized grafts. Now, small wounds in the context of past radiation can even have issues, causing ulceration and infection from opportunistic bacteria. And if the patient has a poor immune response, you end up with progressive necrosis. And you need to remove all that non-vital tissue. A big thing to note is that after the inflammatory process causes disintegration of the soft tissue that was covering bone, healing can't happen because the irradiated bone can't create the granulation tissue. And this means that the surgeon needs to remove all the avascular bone until they reach a healthy portion. So we can't finish talking about radiation unless we talk about hyperbaric oxygen therapy. Now, hyperbaric oxygen therapy is based on the following premise. If low oxygen is leading to anaerobic metabolism, then high oxygen should promote aerobic metabolism. The second half of that, of course, is that we're trying to promote neoangiogenesis. Now, of course, this whole process promotes the growth of fibroblasts and vascular endothelial cells, but a big point here is that additionally, the high levels of oxygen can actually help in killing obligate anaerobic bacteria. And we find that sometimes, depending on the wound, initial infections are actually especially if they're not exposed to the outside environment first, they actually are filled with obligate anaerobic bacteria. Now, in addition, hyperbaric oxygen therapy is kind of controversial still. There aren't enough studies that really look into efficacy with a well-defined endpoint, and there are definitely some risks, including barotrauma to the ear, seizures, and pulmonary oxygen toxicities. So what exactly is HBO? HBO, the hyperbaric oxygen therapy. It's where patients take in about 100% oxygen at an increased pressure, typically 2 to 2.4 atmospheres, for 1 to 2 hours per session. And the process is repeated daily and usually happens for several weeks. Now, on a super small scale, we find the diffusion distance of oxygen going up tremendously, and some studies even suggest that it can help with wound management in diabetics. So the next thing we'll talk about is age and the effect of age on healing. Now, it's no shock and it's no surprise that healing speed is quicker for younger people than older people, and it's for a couple of reasons. The first one is compounded repair. Compounded repair can cause issues with the healing mechanisms, because when we think about the difference between repair and regeneration, repair is not necessarily the return of structural or functional integrity. It's not that far-fetched, especially when you consider potential areas where repair, as opposed to regeneration, occurs multiple times. We know that repair does not result in that functional integrity the same way that regeneration does. So the next piece, of course, is systemic factors, and different conditions, along with the wear and tear of the body, can manifest as compromised regional vascular supplies, and blood supply is paramount to healing. All in all, however, the difference in healing between different age groups in the absence of systemic disease seems to be fairly minimal. So the next piece we'll talk about is nutrition. So nutrition is crucial to healing. Malnutrition can lead to decreased healing, which means decreased fibroplasia, angiogenesis, and remodeling. Now, amino acids are crucial here, and the amino acids that are of critical consideration are histidine, methionine, and arginine. So why is methionine so critical? We have plenty of evidence that suggests it's critical in all three phases of wound healing: inflammatory, proliferative, and remodeling. And it's because methionine is actually involved in two really important processes that have to do with healing. And I'm going to show you a bit of a kind of a picture representation of where those processes are, but we'll talk about it first. So first, methionine is tied into the synthesis of tetrahydrofolate, which we know is one of the functional origins of pyrimidines. And of course, pyrimidines are needed for their nucleic acid generation or synthesis, which we need for cell replication and cell division. And secondly, methionine is involved with the eventual formation of glutathione. And we know that glutathione plays a key role in maintaining a proper function and preventing oxidative stress in human cells. Now, I'll show you a little bit more about that in the next slide, but you can already see that methionine right here is involved with THF and glutathione, right? So the next piece, just another thing to note, is that severe deficiencies can cause decreased albumin in the serum. So we can use albumin to kind of gauge a person's nutrition and their nutritional health when it comes in the context of healing, at least. So when it falls below 2 grams per deciliter, when the serum albumin falls below 2 grams per deciliter, we start to really see prolonged inflammatory phase with all the things we saw above, including decreased fibroplasia, decreased angiogenesis, and decreased remodeling. But in addition, we have issues with collagen synthesis. And while albumin is a valid indicator, we like to actually use prealbumin as our reference parameter because albumin has a half-life of 20 days, while prealbumin has a half-life of about 2 days. And when I started reading that, I was thinking to myself, well, it's kind of interesting because when we try to monitor patients' blood glucose, we actually want the most long-term thing as opposed to the short-term thing. But when we're dealing with their nutritional deficiencies, if we want the short-term thing, not the long-term thing. So those are almost, I consider them almost parallels when we're trying to monitor a patient's state, but we want the opposite things in those cases. Now, typical levels of prealbumin are about 22.5 milligrams per deciliter, and the threshold for a mild deficit is anything below 70 milligrams per deciliter, while the threshold for a severe deficit is anything below 11. Now, preoperative optimization for patients with deficits includes protein-rich diets, especially with glutamine, and bringing the patient back to baseline will typically reoptimize them, but overshooting them won't necessarily speed up their recovery. Now here's that picture I was talking about with methionine. So I kind of pulled 3 different images together. This first image shows how methionine creates glutathione and tetrahydrofolate. Now if we follow that tetrahydrofolate, we can map it back over to this picture from first aid, where we see that tetrahydrofolate can actually be used to convert it's part of the process of converting DOMP to DTMP, right? And the DTMP, of course, is the pyrimidine base. So you'll notice that we actually have these anti-neoplastics that we talked about in the previous video talking about optimal healing, and this is kind of where those anti-neoplastics play their role in causing issues with optimal healing, because we have issues with cell replication, and of course that's because we have issues with the pyrimidine base production. Now, if we follow that path down to the glutathione, we find the glutathione is directly involved with with managing oxidative stresses, because if you follow, we have the oxidized glutathione converted to reduced glutathione, and then we have this section here, of course, and then we have the conversion of water over into peroxide. That's really the big piece I was trying to get to here. And this peroxide, of course, we use that in neutrophils, and not just in neutrophils, but that's just one big place we see the peroxide being used to manage oxidative stresses in the body. Now, moving over to the next piece is just going to be our last piece. We're going to talk about a couple different vitamins when it comes to nutrition and optimal healing. So vitamin A is, of course, it's involved in promoting fibroplasia, collagen cross-linking, and epithelialization. And it can actually re-stimulate all those processes when they've been suppressed from chronic steroid use. So we talked a little bit about chronic steroid use, I think, in the previous video. Vitamin C, of course, promotes collagen synthesis by fibroblasts, and this is because the vitamin C was involved with the hydroxylation of proline and lysine. We also talked about that and highlighted that in the previous video. Now, vitamin C is ascorbic acid, and it's crucial for the production of neutrophil superoxide as well, and a deficiency can weaken the immune system or response. Now, a couple other vitamins of importance are vitamin B and cobalt, and they help promote antibody formation, leukocyte function, and inherently they also increase bacterial resistance. Of course, copper is involved with collagen cross-linking. Calcium is involved with collagenase function, especially but not exclusively in granulocytes. And zinc is involved in a couple different things. A zinc deficiency slows down fibroplasia and re-epithelialization, and zinc is crucial to a number of enzymes. If levels get too high, you get issues with macrophage migration and collagen cross-linking, so you don't want to overshoot these patients either. So zinc is a crucial thing to kind of titrate to the nutritional needs of a patient. So that wraps up the absolute final portion of optimal healing, and in the next video we'll talk a little bit about advances in wound care. All right, so thanks for coming to this one, and I look forward to seeing you in the next one.